I wanted to ask Phil a quick question on this if I could, because I was thinking, these patients have a positive bone scan, a positive CT scan, and typically we say, well, we're done. We've established metastatic disease, they're M1, right? But is there a role for molecular imaging in that setting to really look to see, is there more extensive disease than we thought? Is this the tip of the iceberg?
Right, and that was exactly what my next question is, and also, what do some of these scans, how do they perform looking at the primary tumor itself within the prostate?
Yeah, great question. So clearly, these novel imaging, next generation imaging tools are disruptive. And we've seen that they've performed much better, and it really forces us to think about how we think of low volume disease versus high volume disease, what we could do for primary disease as well. And Neil brings up the two great points in terms of, the biggest fact is that these tools have not been validated in those settings yet. So I think it really is going to require efforts with from a multidisciplinary approach to develop clinical trials that answer these questions exactly. So with regards to lesion detection, all the data shows that on a per patient basis, these tools detect more lesions in more patients. On a lesion by lesion analysis, all these next generation imaging tools detect more lesions than lesions seen in the past. So clearly this idea of one bone scan, tip of the iceberg, one lesion on a bone scan, tip of the iceberg, that's real. I mean, there's clearly going to be more. And if there's not, it's going to be reassuring that there are no more metastatic lesions, and maybe treating that can lead to a quote unquote cure. The idea of primary lesion detection, I think, is a huge area that a lot of people are looking into. And it's being shown, and the group in Johns Hopkins has developed a F18-based PSMA targeted agent that's looking at this, combined with PET-MR, that actually can help us determine which of the primary tumors are the bad actors. What are the ones that you could watch? What are the ones that you actually have to intervene on? And I think that's sort of another area that needs to be further developed, and we'll see more data in regards to primary lesion characterization in the future. With regards to primary disease, though, I think that's probably the next area that we're going to see more implementation of this next generation imaging. All of us have seen patients who present with an elevated PSA, high Gleason score, that have a negative bone scan in CT. And I don't have to tell this to you guys, but you guys know there are METs just waiting to be detected. So now we have a tool that will detect these lesions. So we see a lot of patients in that category that are, pursuing next generation imaging, whether it's Axiom or PSMA, and we're seeing these metastatic lesions.
I mean, I think one of the things, and having grown up in an era of open prostatectomy as opposed to robotic, I was always tried to be very aggressive in taking out the primary, not because I thought it was curative, but just we know that if you didn't take out the primary, these people would have horrible local disease once they blew through hormonal therapy and those types of things. But I think there's actually some pretty good next generation sequencing data to suggest that you do have to be aggressive with the primary because of this seeding and branching effect and going back to reseeding the primary, which to me is, a little bit scary actually.